emergencies. I will let him introduce himself. Thanks, Antonio.
Yeah, thanks, Dave. I'm so excited to be able to come back and speak to this wonderful group. And yeah, so today we're going to cover intussusception and other abdominal emergencies. And intussusception is actually a topic that I'm quite fond of. It's one of my favorite, if not maybe my favorite POCUS topic. And I could easily do an hour plus on intussusception alone. But Dave and Nigel asked me to try to add in some more, sprinkle in a few more topics and applications, which we'll try to do towards the end, the second half of the talk. But we will do a bit of a deep dive into intussusception because I do think it's worth our time as PEM physicians, acute care physicians, and then we'll touch upon some other applications as well. I don't have an easy way for those who joined a little bit later, an easy way to look at the chat. So please interrupt me or have Dave ask me, interrupt me so that I can address any questions during the talk. We can make this as informal as it needs to be. All right, so we're going to review pediatric ileocolic intussusception. We'll discuss, yes, mute my phone, discuss some image acquisition, interpretation, and clinical pearls. And oh, my presentation is just going. Okay, let's just go back really quick. Sorry, guys. After dissection, we'll do pyloric stenosis, small bowel obstruction, malrotation of volvulus, and a little bit of unconstipation. But before we dive into intussusception, I just want to pause and talk about Hercule Poirot. So I don't know if you're familiar with this Agatha Christie character. He was a refugee Belgian detective who actually teamed up with, I believe there were some other British characters, Chief Inspector Japp from Scotland Yard, and his sidekick was called Captain Hastings. And I'm a sucker for sort of mystery detective novels and miniseries. And Hercule is far and away my favorite of all the characters. And he's just so unique in his style. He will often refer to the little gray cells, so which I think really applies to POCUS. And one of the reasons why I think AI will never replace the people power needed to drive POCUS and to do POCUS well, because you really have to think through not just the image acquisition, but how to actually interpret what you're seeing on the screen. The other piece that is really interesting with Poirot is his obsession with order and method, which I actually think comes across clearly in like his outfit. It's always so perfect, and his mustache is pristinely trimmed. And I think that's something that we could apply to how we do our scans with order and with a method, and it's going to apply when we talk about how to do an intussusception point of care ultrasound. And yeah, he's just like a real fun character. And if you ever watched his mini-series episodes, he sort of builds up all the work, the observation, and at the end gathers all the potential suspects together and sort of methodically disproves why some folks are innocent, and then gets to the big reveal and kind of casts the finger on the criminal. So anyways, great character, Agatha Christie. And he's going to help us with some of these case presentations for the intussusception piece.
Mes amis,
Oh,
the only
sorry.
offender.
If Poirot was the other thing, Hercule, I'm sure, if he would have used ultrasound to help solve his cases if that was something that actually would be a thing. And then he would pitch it as something along these lines.
Mes amis, you see only a shadow on the screen, a blur, a flicker, a suggestion. But I tell you, the image does not lie. It is not the machine that makes the diagnosis. None. It is the little gray cells. You have the probe. You have the patient. You have the question. Now, arrange the clues. Is it fluid or artifact? Is it pathology or perception? Observe, Be orderly, be methodical. And when the image confesses, you must be ready to listen.
All right, so let's dive into what we're here is to talk about point-of-care ultrasound.
Numéro 1.
So this was my first case, my first intussusception case as a fellow. I barely had my feet on the ground. I could barely, come up with a differential diagnosis that my attending liked. And so this was my introduction to intussusception and what actually caught me, as you will see, quite off guard. So it's actually not a complicated story. It was a 5-year-old boy. He presented with 2 weeks of green, non-bloody diarrhea and some vomiting, but had developed bilious vomiting, which of course is a red flag, in the last 24 hours, including one episode in the emergency department. He was having diffuse, crampy abdominal pain, so not coming and going, just sort of crampy, diffuse, generalized. And then both of his parents had had a gastroenteritis that had improved, but this kid's symptoms were still ongoing. And he had actually had prior outpatient stool studies for colitis that had come back negative already. And this was him in the ED. So right before I met him, he actually had like an explosive diarrhea and was thirsty, was like asking to drink. Afebrile, heart rate, not too bad for a 5-year-old. Blood pressure was fine. His oxygen, respiratory rate were fine. And on examination, he was diffusely tender, but it was kind of more subjective. There was no guarding. There was no peritoneal signs. And you can see here sort of some review of systems, nothing too helpful, fatigue, malaise. He actually never had a fever, a little bit of weight loss. He'd been sick for a couple of weeks. That's not surprising. Little bump in the white blood cell count, and potassium was a little bit low, presumably from all the diarrhea. An x-ray was obtained, and you can see, let me put my laser pointer on. So here's your supine film. Here's your upright film. Can anybody see something off in these x-rays? You could either shout it out. I guess you could put it in the chat, but I won't be able to see your chat. Especially on this x-ray. So there are some air fluid levels here. You can see them sort of tracking up and down, which signifies the value of getting it upright and not doing the supine. But it was actually read as non-obstructive gas pattern. And then the air fluid levels that's seen throughout the colon and the rectum. And then the radiologist said that this was consistent with enteritis. So we do some IV fluids, we do some potassium. Our working diagnosis is enteritis with dehydration and probably an ileus because of all of the diarrhea. However, because of the bilious vomiting, I was working with a very astute attending who said we should probably just have surgery, kind of do an evaluation in the ED sooner rather than later. During the surgery exam, developed more right lower quadrant pain, and so was admitted for serial ultrasounds because at that time I didn't even know how to turn on an ultrasound machine. And we actually didn't have like a great 24-hour overnight ultrasound capability. So this was many, many years ago. So he was admitted to get an ultrasound in the morning and serial exams for appendicitis. And the idea behind the ultrasound was to make sure that we were missing an appendicitis, with like a perforated appendicitis, I think would be reasonable in a case like this. Only 5, so we tend to not to go straight to CAT scan. The kid vitals were stable. The exam was not peritoneal. And so gets an ultrasound the next morning, and we have this. So it's like, what? I was home. I'm like following up on the patient. I'm like, how could that 5-year-old kid have intussusception? He had none of the hallmarks of it. He didn't have any bloody stools. He was old, relatively old. He didn't have pain that was coming and going. Makes no sense to me. So anyways, I feel terrible. How did we miss this? We could have diagnosed this in the ED. Now with a point of care ultrasound. So we live and learn. So like, what the heck happened? So now we have so much more information on intussusception and pediatrics, with all the work that's been done with the P2 network and beyond the P2 network as well. It is the most common surgical emergency of infants and toddlers. Abdominal pain is the most common presenting symptom. And then a key thing here I would say is that abdominal pain episode is often not present at the time of diagnosis. And so I have found that most of the times when I'm able to rule in an ileocolic intussusception, the kids are just kind of laying there like lethargic, and they couldn't care. They couldn't care if you're scanning them or not scanning them. So the kids that are usually miserable during the ultrasound scan, they may have something going on. They may have small bowel intussusception, but it's unlikely that they're having ileocolic intussusception. Anyways, fussiness and lethargy are important symptoms to recognize, especially in the younger infants. And then early on, your physical exam is not going to be helpful. Might have a little bit of diffuse pain, but this slideshow just wants to keep going. You might just have a little bit of diffuse pain, no focality, maybe a little bit of belly distension, maybe, but it really is a soft abdominal exam overall. And then what the heck causes intussusception, where most of the time is nothing. It's just idiopathic, random pediatric emergency stuff. 1 in 4 cases we do have to deal with a lead point or something pathological. At our hospital, our pediatric surgeons don't start fishing for lead points until 2 or some of them wait till maybe even a 3rd episode of intussusception to get cross-sectional imaging, because the vast majority of cases are idiopathic. Okay, so this was the P2 network study from 2021 that looked at performance of point-of-care ultrasound, mostly well-trained folks, compared to radiology, performed ultrasound for the diagnosis of intussusception. What I think was a incredible strength of the study is that they described the demographic and clinical characteristics of the patients that were working up for intussusception. And so, to nobody's surprise, abdominal pain and fussiness were very common, but they're also very non-specific. They're also symptoms that fussiness could be an ear infection. Sorry, abdominal pain could be gas, could be constipation. So any non-specific symptoms that are common. And then the less common is what we learned in medical school, what I learned in medical school, is the current jelly or bloody stools. And I think part of that is because now we're sort of thinking about intussusception a little bit earlier in its pathophysiology. And so we're not waiting for kids to develop bloody mucousy stools to start thinking about ruling out this diagnosis. So it can happen, and it doesn't always mean that it's going to be a disaster, but it is a much less common presentation than belly pain, fussiness, even vomiting, colicky abdominal pain, poor feeding, etc. Has anybody seen a current jelly bloody stool? I may have seen it like a couple of times.
So Antonio, I'll jump in.
Yeah.
We've had 3 cases in the last 3 or 4 months, and I was asked to go and look at a kid about a month ago up on the ward. Normally, like you, work in PZD, and this little boy had been admitted with low saturations. It's a very similar story to yours. He was younger. He was 2 years old. Low saturations was why he was in. Sat there for sort of 24 hours, and as they asked me to go and scan him, he produced the stool at that point. Big. It was, I mean, mucousy, but really melina, that horrible smell, like reminds kind of adult doctors from working on an adult ward, an elderly care ward, 10, 15, 17 years ago for me. So yeah, that happened at the point of scanning actually, and it was a clear ileocolic. So that was the only example of as you described, the later finding.
Yeah. Do you know how long that particular kid was having symptoms for?
I guess certainly it would have been like 48 to 72 hours, definitely.
Yeah.
But
okay. Yeah, that makes sense. So yeah, we try to think about it, especially with the kids that are reduced with a shorter duration of symptoms actually have better outcomes. They're less likely to have recurrence or a failed enema. So it's always good to think about early on in the pathophysiology. And with POCUS, you could do we can now screen at the bedside, and I think it's it takes a little bit of training, a little bit of comfort to get there. But I think it's an application that is so high yield for us to learn and to do well.
Antonio, just from the chat earlier on, there was a question, and it was just about why was your abdominal X-ray done? I don't know if that's going to be more reflective of healthcare where you are compared to where we are, but
Probably healthcare in the United States. I think bilious vomiting, and just to make sure there wasn't, grossly dilated bowel loops or something that looked like a volvulus, or because volvulus can present also it's not just newborns. It can also present in older children. Essentially was the reason why. I did just to point out for the consensus point of care ultrasound applications for pediatric emergency medicine training, identification of intussusception is one of the applications that we feel, certainly in the United States and Canada, we need to treat our fellows during their PEM fellowship. And this is my rating for a point of care ultrasound scan. So for intussusception, it's relatively easy. So you get a 5-star rating. It's easy to do. It's fast to do. It's a yes or no question. High impact, of course. And then the performance of ultrasound is incredible. Now, specificity isn't as good as sensitivity. This is for ileocolic intussusception. And this is data from pediatric radiology and more on the radiologist side. And then when we've looked at clinician side, so point of care, either emergency physicians or pediatric emergency physicians compared to radiologists, we have fairly similar sensitivity and specificity with good confidence intervals there. And so this, I think, is all the studies combined. So this was a systematic review meta-analysis, which was published in 2022. And then this looked at all the studies. So 11 studies, more than 2,000 children with a prevalence of 14.4%. And again, you can see sensitivity and specificity in the 90% range. So this is something we should be having confidence. Confidence in being able to do and to do well. All right, so another case for you to consider. This was the.
C'est une bonne chose que vous ayez vérifié, mon ami.
Poirot says it's a good thing that you checked, my friend, because this one was definitely my most fortunate to diagnose. This is a younger girl, 6-month-old, woke up from a nap. That's it. She woke up from a nap during the day with vomiting and lethargy. That was the story. Vomited without like a regular episode of vomiting, then was unresponsive for a couple of minutes. She had color changed at some point, appeared purple to the parents. The parents actually were only Spanish speaking, had no fever, no diarrhea, no bloody stools, and then went to one of our community hospitals because it was closer for the family and had an extensive workup. I got the kid at about 4 o'clock in the morning. I was doing an overnight shift as an attending. But this is the workup for this poor girl. All this little infant did was take a nap, and then she woke up from a nap like with concerning symptoms. I mean, lethargy, vomiting, color change. The differential is pretty broad from sepsis to non-accidental trauma. So at the outside hospital, they noticed she was lethargic, but the vitals were okay. They couldn't get an IV. So she actually came to our hospital with an IV in her neck, which is for a 6-month-old, that's not very common for us. Required an IO, which infiltrated. So that wasn't great. There's the external jugular line was eventually placed. They had a head CT, negative. Had a lumbar puncture, it's fine. Bolus, IV antibiotics. So she didn't need any of this. She just needed a point of care ultrasound to rule it intussusception. So anyways, they eventually got to the intussusception diagnosis, and then it's a community hospital, so it has to be referred to us to have definitive care. And this was actually the pictures of her. We do pneumatic reductions at our site, not saline enemas. We do air enemas. And then at 1 o'clock in the morning, you could see here is the improvement of the caliber of the bowel. the intussusception is happening over here. I'm not able to really explain the appearance of the intussusception well on an enema, other than look at these proximal dilated bowel loops that resolve once that intussusception is reduced. And so we have actually some discharge criteria based on some of the literature on intussusception and recurrence. And so if families live locally, and if the duration of symptoms is less than a day, and if they're able to take a little bit of PO and no fever, and their abdominal exam is okay, then we feel like they might be candidates for discharge. But in this case, I thought this was a video. I guess this is not a video that's playing. Oh, how annoying. So in this case, what I'll share is that this 6-month-old was sleeping. She had like breastfed a little bit, had a little bit of spit up after breastfeeding.
Antonio,
And,
sorry, if you take your laser pointer off, does it allow you to go back to cursor? Does it let you play it?
Oh yeah, brilliant.
Yeah.
Thank you.
No bother.
I thought it was a video. So we'll play the video. So again, we have this discharge criteria, and overnights in our hospital, we tend to work with the residents, and I think sometimes the residents have slightly different priorities than the attendings, who are ultimately responsible for the ultimate care of the patient. So just given the story, this should have just been an automatic admission for observation, in my opinion, after air enema reduction. But of course, the resident's like, no, the symptoms less than 24 hours, no fever, if she could breastfeed, because they're just following the discharge criteria. They kind of live locally. So so this is bonkers. And I literally, because the family only spoke Spanish, I went into the room with the discharge paperwork in my hands, and I looked at the kid, and the kid is just asleep. She's just like asleep on the bed, on the stretcher. And I said, I can't do that. I can't do this. Let me grab the ultrasound machine just in case. And would you believe it? This was the point of care ultrasound I did as I had the discharge paperwork in my hand. And surely she had recurrence of intussusception, even though she had just been reduced a few hours prior. So I will almost routinely now, because of this one case, do a pre-discharge point of care ultrasound, just to prevent sort of the back and forth that would likely ultimately happen. And after this, the radiologist took a look at it, and they said, yeah, this is looking like it intussuscepted, and the went to radiology again, and then during their ultrasound, it's what we have one. We call him a magician because he can find everything on ultrasound, and he can do all sorts of things that other people can't do. And he actually was able to, maybe it spontaneously reduced, but he said he kind of like just pushed it a little bit with the probe, and it was a short segment re-intussusception, so he was able to get it to reduce. And anyways, we admitted the baby, and the baby did fine. But let's talk a little bit about how to do this study. So usually you're going to want to use a linear transducer. And our yes or no question will be, do I see a target? Do I see a target sign? So what makes the target? So you have the terminal ileum here. Oh, here, wrong. Terminal ileum here, and then the cecum, so the colonic part, the ileocolic. And so the intussuscipiens is the colonic part. It receives the intussusception, which is the ileum part. And it just looks like a target, like a bullseye sign in short axis. There are some secondary findings. They're not as important, I would say, as getting really good at this pattern recognition, at this visual diagnosis. And so the way we were taught to do it by our radiologist was to do an inverted U. So you start transverse on the right lower quadrant, and then we'll find a landmark here. This is part of Poirot's order and method. So we will identify the psoas muscle, and I try to teach our fellows, do not start sweeping all over the abdomen until you can find the psoas muscle for me. And if they have a tough time finding the psoas muscle, and I'm there with them. I don't let them move on. You find the psoas muscle, find those iliac vessels. Once you identify that, you can do your intussusception inverted U sweep, which inverted U, it's not that complicated. Transverse, and then you sort of rotate the probe, longitudinal, come across, and then you do the left side here. The other line of thought, which is fine, is they say mow the lawn. So you just sort of keep the probe in a transverse orientation, and you kind of start on the right side because most intussusceptions are right-sided, and you sort of sweep up and down. And if you wanted to do both, that's fine. Like if I have a high index of suspicion, I might do an inverted U, and then come back from the left side to the right side in sort of like a lawnmower type technique. So some pitfalls would include their depth. So here's a linear probe, but the setting was set at way too much depth at 9 centimeters here. Every dot here is 1 centimeter. And this is the same patient as this, but you can see the target much more clearly when you set the 4 centimeter versus 9 centimeters. And then the curvilinear probe, you will definitely lose some resolution. And then this is all unused space here. This is one of our, when we started looking at this internally in our hospital, this was one of our false negatives. It just wasn't recognized as intussusception. It was felt to be a kidney when the sonologist was doing the scan. So linear probe, I usually start around 5 centimeters, and then you were looking for a target sign.
Écoutez le signal.
All right, so here's another case. I would say one that I was lucky to diagnose, and Poirot says here, listen to the signal. Okay, so severe acute pain matters. If it happens at home, even if it gets completely better, it matters. That is signal. So this was a 4-year-old male who had a fever for 3 days, and the sibling had a GI illness that got better, and he had no vomiting, and then had an intense episode of pain witnessed by the pediatrician. She said it lasted 10 minutes. She was really worried about intussusception and got sent into our emergency department. Kid got ibuprofen, pain resolved, and actually had tonsillitis, had pharyngitis, tonsillitis, the rapid strep. It was negative. And then the kid looked like this. When I saw him, this was the kid. He was smiling and playing and looked perfect. His belly was soft. He had no pain. He had tonsillitis. And I was, we make comments, oh, why did the pediatrician send this kid in? This kid is fine. Unfortunately, this is the way that we sometimes think because we're so busy. And then I said, well, I better just get the ultrasound for the pediatrician out of respect to being collegial. But this kid was perfect. I will tell you, this child was perfect. And I was embarrassed because this was the radiology scan. And I said, I don't believe it. I don't believe it that they saw it in radiology. So then I grabbed the point of care ultrasound machine and I did a point of care ultrasound, and he had intussusception. I couldn't believe it. Adenovirus was positive, and it was lucky because this is the kid that gets sent home and comes back the next day and is more of a disaster the next day. So intense abdominal pain episode that gets better matters. Such an easy rule out. Point of care ultrasound, just do the scan. Good outcome, successful reduction. I was at a community hospital during the shift, got referred to our New Haven site, and that's where we do our enema reductions. Okay, so starting landmark, order and method, where is the psoas muscle? So it sort of depends on where you're scanning. If you're higher up in the abdomen, the psoas muscle is going to be right next to the vertebral body. If you're bringing the probe lower into the right lower quadrant where we typically start, the psoas muscle, which looks like a meaty structure with some white striation, little white striations, a little bit of fascia anterior to it, is going to be off the vertebral body and right next to the iliac vessels that are going to run medially. When you're starting to learn to scan, you'll recognize the iliac vessels, but you may not recognize that they're iliac vessels. You sort of see something there in the right lower quadrant, and you put color Doppler, you will see pulsatility of the iliac vessels. And this is what I ask our fellows to find before starting to do an inverted U. That's how we were taught to do it. I think it's a good strategy because, one, you don't confuse a psoas muscle as a potential intussusception, and two, it just gives you an order about how to do this scan. So the psoas muscle looks different, and not every kid has a big round psoas muscle. Some kids have a thinner, kind of more irregularly shaped psoas muscle, but here in the right lower quadrant, it is right next to the iliac vessels, and here you can see normal appearing bowel peristalsing above it. Things that you may see. You may see fluid inside the lumen of bowel, especially kids with gastroenteritis. You may see air inside the lumen of bowel. You get A-line artifact from air or dirty shadowing from air, and you don't see anything. Or you may see some stool inside the lumen of bowel, as we see in this patient here. But what we're actually looking for is the target, ileocolic target sign. So big circle on the outside, smaller circle. This is the ileum piece on the inside. Every once in a while, you'll see a lymph node entrapped inside of the intussusception. Those are kind of fun to find. And then if you see something in short axis that is taking up the majority of the screen, you're going to rotate the probe 90 degrees and then visualize it in long axis. And here you can see a nice image of, this is the intussusceptum portion here, the ileum, kind of invaginating inside of the intussuscipiens here, the colonic cecal portion here. So just let that play for a quick second. And you can clearly see that that's almost like a mass there, a target-like mass there in the right side of the abdomen. There's a coin for a pseudo kidney sign that typically will happen if you're catching the intussusception in an oblique type orientation. I guess it kind of looks like a kidney, but you know, you're not seeing those calyces or those sort of collecting system findings. So hopefully we won't misinterpret something like this as a kidney. Just be aware that there's a pseudo kidney sign sort of terminology. It doesn't come up that often where we're sort of misinterpreting a kidney for an intussusception just because of like where the probe tends to be. And if you're in doubt, then just bring the probe more to the flank and more posterior and see the kidney and say and prove to yourself that the kidney is separate from that intussusception. And then trapped fluid will sometimes be seen within the intussusception, can be a sign of you know, an intussusception that's been present for a longer period of time, just sort of implies a little bit more edema that's been going on for longer. But again, you see a big target here, positive target sign, positive intussusception. I don't do much color Doppler. You'll see in the radiology literature that it's suggested that intussusceptions that have devoid of color Doppler flow are less likely to have successful reduction, which makes sense from a physiologic standpoint. It might imply more edematous tissue or more necrotic ischemic tissue. But in practicality, I don't use it much, if at all, for my screens, for my intussusception screens. All right, so we have predictors of failed enema reduction. I think these are important for us on the emergency side to be aware of, and you know, limitations of retrospective retrospective studies aside. This is a meta-analysis of 40,000, more than 40,000 cases of ileocolic intussusception, 38 studies. And so a shorter duration of symptoms, less than 24 hours, means you're more likely to have a successful enema reduction. And then the factors associated with failed reduction. Oh, sorry. included younger age, the presence of rectal bleeding, vomiting. I don't know what to do with that too much. And then some fever, so the presence of fever. And then concerning findings on ultrasound would be if it's a left side intussusception, if there was ascites associated with intussusception or trapped fluid associated with intussusception. So potential warning signs that the enema may not go as well as we would like. And for recurrence, so separate question, not failed enema reduction, for recurrence, if there's a lead point or if there's fever, they tend to have be predictors of recurrence. So the kids with fever, I almost universally try to admit for monitoring for 24 hours, even if they have a successful air enema reduction on initial presentation. And that's part of our sort of discharge criteria pathway in our hospital. We were always taught that the recurrence rate is about 10% for intussusception. And so, you'd have to admit 10 kids. You have to admit 10 kids to prevent one kid from having a recurrence. And that was all comers. But it is a bit of a, I think, conversation to have with families. If families are reliable and live close by and you can give them the signs to come back, I think it's also reasonable to do it that way. The kids that are sicker, I'd probably just keep an eye on them in the hospital a little bit longer. All right. And then one last case.
Bien avant de commettre le crime.
And we'll switch gears. So this is the one to remember. And here, this is what we'll hopefully try to avoid happening if we do a POCUS first mentality for intussusception. Poirot says the illness leaves clues long before committing the crime. And so this was a 10-month-old who presented with vomiting, non-bilious, non-bloody, diagnosed with gastroenteritis, sent home, did a PO trial at the hospital, sent home, and then returns with persistent vomiting, but now is in respiratory distress and in shock and has a high fever. And the team is concerned about sepsis and pneumonia, and also gets an intraosseous line. And then this kid is super sick. So this kid went from not sick, benign exam, just a gastro, most likely, which honestly is what 99 times out of 100 is probably the case, to now septic shock picture on oxygen. And there's a kid with the IO, and there's an x-ray with air fluid levels, and this kid is too unstable to leave the emergency department. So we don't know that there's intussusception going on. So we do a shock evaluation for undifferentiated shock at the time, not cardiogenic. We have good function. The vena cava, if anything, is completely flat here, pretty dry. The lungs look good. And then when we start looking for intra-abdominal free fluid with the curvilinear probe, we see this. And then that's the target right there, liver, kidney. And then if you switch to the linear probe, you can see that target much more clearly. And again, this kid was too sick to go off the unit, to go to the radiology suite. So we would have, I don't know what we would have done without point of care ultrasound. There you go, target sign. But anyways, this child was taken to the OR and based on the point of care ultrasound and the clinical picture, and then unfortunately required multiple bowel resection surgeries and developed short bowel syndrome and needed TPN for a little period of time. So very high morbidity for something that, maybe 24 hours prior, had we made the diagnosis by just like thinking about looking based on the age, infant, and then just vomiting as a presenting symptom, we may have been able to prevent this. But anyways, that's one of my dreams for us in PEM for intussusception evaluations. Now, small bowel intussusception, it's very frustrating because it kind of, the symptoms mimic, sorry, text message that I have to look at because of the snow. Okay. So small bowel intussusception, very frustrating because the symptoms mimic ileocolic intussusception, but the treatment is very different. It's more going to be more medical management and not surgical management. And so things that will help you differentiate small bowel from ileocolic include the size. So we usually talk about a diameter more than 2.5 centimeters for ileocolic intussusception, and smaller than that for ileal or small bowel intussusception. The location, so if it's left lower quadrant and small, it's probably left lower quadrant and small, it's probably going to be a small bowel intussusception. Even if you don't see it self-reducing when you're doing a scan. If you're lucky, you will see it reduce on its own. That's kind of reassuring, but it may not. Sometimes our radiologist will look for 5-10 minutes in small bowel, and it doesn't reduce. And so it's sort of a bit of a clinical conundrum because the symptoms might still be recurring or present, but there's nothing that an air enema can do to help with that sort of location of that intussusception because it's past the ileocecal valve. So the air enema is not going to be able to get there, or saline enema, whatever type of enema, hydrostatic enema. So it's tough. Sometimes these kids need a little bit of time, a little bit of supportive care, Tylenol, ibuprofen, and then sometimes they're miserable. They need to be washed in the hospital and get some IV fluids if there's signs of dehydration. So the small bowel intussusceptions I sort of manage on a case by case basis, depending on how severe the symptoms are presenting for the child. And here's some examples of small bowel. Small bowel. Can anybody tell me what this is here? Anybody want to shout it out if anybody's still hanging on?
The bladder.
It's a bladder. Good. Yeah, it's a linear probe. So so you're just catching half of it. So you're not seeing it like that little toast-like configuration, and it looks very round and kind of cystic. But this is the bladder, and so you have to the left, because the indicator's here, to the left of the bladder, a very small intussusception that doesn't reduce during the scan, but it's small bowel because of the size, and it's left-sided. And then here's one that's actually reduced. You can reduce for a nanosecond there, and it's reducing during the scan. So I've had rarely some small bowel to small bowel, large bowel, sort of in between measurements. So if this one was 2.3 centimeters, that's why I'd like the measurement. I think it is it's good to guide, sort of like your suspicion of what type of intussusception it is, but I wouldn't use it as an end all be all. This was actually a smaller kid, a 2-month-old, who did in fact have ileocolic intussusception that measured under 2.5 centimeters, but just because it's a smaller kid. What are all these videos? So here's just a video clip of the intussusception. You can see it nice and clearly. It's a little bit kind of ovally, I guess, and that's why the AP diameter is under 2.5 centimeters. If you measure this way, certainly going to get more than 2.5 centimeters. And then this is just, I think, an arrow pointing at the liver, the tip of the liver, just to say that this is right upper quadrant, right next to the liver tip. So location, right? It's not left-sided, it's right-sided. So this is one you get consultations with radiology and surgery and go ahead and reduce. And then this child was a 5-year-old who essentially had Henoch-Schönlein purpura and actually did have small bowel intussusception, but it just never improved after multiple ultrasounds. You can see the difference here. These are radiology images, so I don't have video clips, but you can see how thick the bowel wall is, and this disease can be pretty bad from an abdominal pain standpoint. So she actually ended up having to have a manual reduction in the OR intraoperative because there was no other way to manage her. And it's just such a profound inflammatory process for the jejunum. But for the most part, small bowel is pretty benign. And then just a shout out, kudos to the group at Sick Kids. Love this study. POCUS, first pathway to streamline care for children with suspected ileocolic intussusception. And what are the benefits? Well, it's shorter duration, time to reduction, shorter time in the emergency department. So all these metrics are actually important for administrators. And then better decision making for interventions like consulting IV access sooner rather than later, and things like that. So really nice study, very simple study. And then this is it for the interception portion of the talk, which took us 45 minutes, which I'm not surprised. So I'll try to get through some of the other topics. Um, um,
Antonio,
as
can I ask
best
you a
I
couple of
can.
questions from the
Yes,
chat?
please, Dave.
Yeah, so one of the earlier questions from one of my colleagues, Emily, she was asking really about false negatives in the POCUS diagnostic accuracy study. So it was very good sensitivity, but was there any indication of what factors reduced that sensitivity in terms of, is that likely small bowel, or is that intermittent, or was there any shedding any light on that, or personal
Yeah,
experience?
that's a great question. So false negative ultrasound for ileocolic interception. So uh, if assuming we're not using the wrong probe, like a curvilinear probe instead of a linear probe, or selecting a depth that's suboptimal, so too much of a depth, which will really impact our ability to interpret the image because you won't get as nice of an image. One of the things to consider, which has been reported in the literature, and actually we wrote up a case report, is that ileocolic intussusception can reduce spontaneously. The number that is thrown out there is about 5%, 5 to 7% of the time. And so the majority don't. So I think, I think if you have a kid that has intussusception-like symptoms and you look and you don't see it, it's possible that at the time of your scan there was a spontaneous reduction of that ileocolic interception, and that would be a false negative because of the intermittent nature of the disease. And so the case that we wrote up was essentially that was a kid that had a obvious intussusception on point of care ultrasound, and then our radiologists have to get called in from home. And when the radiologist came in 3 hours later, they looked and it had resolved. It had spontaneously resolved, and they saw a terminal ileitis, so an inflamed ileum on their scan. So there was still actual evidence of inflammatory process. But that's a great question. So I would say, your image acquisition, optimize it to reduce your likelihood of getting a false negative. And then there's a small chance that an ileocolic interception self-reduces. Unlike small bowel is the expectation is that it's going to reduce on its own.
And I must admit that you've touched on a point that's always a worry of mine, Antonio. You do a scan, you're certain it's appendicitis, you're certain it's, for example, these last two cases of intussusception. You always think, for us, little ones get transferred out to an external hospital for a tertiary centre. And I always worry about it reducing en route and thinking, and definitely, there's no question about what we saw, but it could happen.
Yeah, but
And
what are
then
you gonna do? I mean, I would just save an image or take a picture on your phone. I don't know what you're allowed to do, but what are we gonna? I mean, that's like imperfect medicine, but we know it is it's possible, and I think if you have an ileocolic interception kid, you have to just act as if it's just gonna get worse, but not get better on its own.
Yeah, and then just one more question, Antonio. Really good question. Someone's asked, how would you optimize your image if the abdomen is filled with air? So I guess that could be interluminal or external.
Oh,
And I
I
think,
love that question. Yeah, so unlike malrotation, so I don't even know if we're going to be able to get to malrotation, but like malrotation, to really see the SMA and SMV orientation in the mid abdomen, if the belly is full of air because of what's going on with volvulus and proximal air, you're not going to be able to get great images of the SMA SMV. For interception, the pathophys is actually different, um, in that it is essentially a mass that takes up 30% of the abdomen. And so there is not going to be air trapped within that ileocolic intussusception. So I am less worried about missing an intussusception because what I'm seeing is air. Because if that interception is there, the air is going to be displaced from that area where the interception would be, if that makes any sense. And that's been my experience. I haven't had a case where I missed it because, or radiology missed it to my knowledge, because we were just seeing air and not being able to see structures deep to air. Because the intussusception just sort of takes up the place of that. It's such a relatively big mass for like an infant. It doesn't even like you don't even have to move the probe that much. I mean, we talk about the inverted U and coming up and around, but if it's there, it's just there. If it's stuck, it's stuck. You're gonna just see it. So I get a little bit less worried about missing it because the artifact that I'm seeing is mostly air. But that's a great question.
Thanks.
All right, so yeah, let's try to cover. What do you prefer? Let's try to cover pyloric stenosis and then malrotation. I think because otherwise it'll probably just get into too much past the hour mark. So pyloric stenosis less of a acute emergency compared to intussusception, but we deal with it on a semi-regular basis, semi-frequent basis on our differential for the young infant. 2 weeks to maybe 2.5 months, maybe 2 weeks to 3 months with vomiting, who's losing weight, the hungry vomiter, non-bilious vomiting. That's typically the picture. The palpable olive is something I've yet to be able to feel. I don't know how you have to probably have a pretty emaciated kid, which we don't tend to have that much in the U.S. To feel a lump there in the middle of the abdomen. So I don't go by that too much. In terms of thinking about ruling out the diagnosis. It's relatively easy to do. I would say it'll take longer than an intussusception scan. It doesn't hurt, like appendicitis might hurt when you do an appendix, but pyloric stenosis doesn't hurt. And then it's not really a yes or no question because we're doing some measurements that can get, excuse me, a little bit tricky. But the test characteristics for ultrasound are pretty good. So not quite the 5-star rating, but like a 4-star rating from a POCUS perspective. It's not bad. These are the numbers for pediatric radiologists. And then it actually hasn't been studied in big numbers from a POCUS standpoint. I think this is an application that's probably more geared towards waiting for the radiologist to do it. It's not as urgent to make a rule out, but Adam Sivitz, who's like an abdominal ultrasound guru, did publish a single center study, and it's hard to believe these numbers, but when you know Adam, you can believe these numbers, but this isn't generalizable data for all of us. So anyways, that's the only thing that's published, and so I reported here. But that was, 2013, and we haven't done anything related to pyloric stenosis since then. All right, so it's also going to be a linear transducer scan. And then what our radiologists at one point wanted us to just think about qualitatively just ruling in and ruling out an intussusception without even doing like measurements. They said, oh, just look for a hamburger or some people say a hot dog. And then for the measurements, I'll remember pi. So kind of a lot of food analogies for pyloric stenosis. And so, hold on, I gotta, sorry, this snow is causing havoc.
Just laughing there because you've said hamburger. I was laughing at myself because it's been rude because for a hamburger, certainly in this country, when they're doing like antenatal scans, they'll say male or female, look for the hamburger for a female. And obviously the other way we talk about a pylorus is the cervix. So I got where you were going with that straight away, and it does look like
I'll try to say. So this is the hot dog or the ham. This is the bun and a bun, and then this is the fixings on the inside here. So bun, fixings. And so if the pylorus is cooperating, you'll see it under the liver edge here. Sometimes that pylorus will wrap around behind the stomach. So if you have a tough time finding it on the liver edge, that's probably what's happening. This is a scan that you're going to want to do with some warm gel if you're able to, just because the little ones are really sensitive to temperature. And so the cold gel, cold probe, they're going to be crying and fussy and really uncomfortable during the scan. And then this is one that you want to do a little bit of Pedialyte just to give a little fluid-filled contour into the stomach. It's going to really help you visualize that pylorus. You could do it supine. If you don't see it supine, you could do a little bit of a right lateral decubitus position just to get the virtue of gravity of the pylorus to come down towards the probe. And so here are some of the measurements. So this is a muscle wall here. That's 5 millimeters. So muscle thickness is 3 to 4 millimeters. And then the channel length you sort of have to measure from the antrum here to the edge of the pylorus here. And so I'll just try to remember pi because it's 3.14, and I'm trying to simplify my life as much as possible. But at the end of the day, you're looking for this bun, this hamburger, this big, thick sort of muscle, hypertrophied muscle. Here's another pretty good, solid example. Looks a hamburger, and then you get this invagination of the antrum here because of the swelling of the pylorus, and that has been coined the antral nipple sign. And then here's a nice little Pedialyte contrast. Another. Well, what do you think? Positive or negative? Just looking at it for this one. Anybody want to?
20 out of 20 are going to say positive.
I think so. What about this one?
Which one? Can't see where you're pointing.
Yeah,
I mean, they're all.
You can see my arrow. That one's
They're all
positive.
looking positive to me.
Positive. And then this one, this one's a tougher one. I don't.
Could be pylorospasm.
Yeah, pylorospasm.
You've got a little antral nipple, it looks like, but that could be temporary. It's quite short. What's your measurement?
It's short. So
0.9.
here it's a little
quite
small,
short.
the measurement. Yeah, about 1 centimeter. So not quite the 14 on the length, and then there's no measurement for the thickness. But anyways, I see a ping pong paddle there. I don't see a hamburger. But sometimes the measurements are, I don't know. I mean, I like to measure things, and I will, but the measurements for POCUS to me kind of add a different level of complexity. I almost like go by the qualitative evaluation. But yeah, Dave mentioned what are the pitfalls. So pylorospasm, super annoying. If the wall measurement includes the channel, you can so if you're doing the caliper with inside the channel, you're gonna get a falsely larger measurement than what the thickness is. And then the probe. So if your probe is perpendicular, your wall here is going to be, if the ultrasound beam is going perpendicular through the pylorus, then you're going to get a more accurate measurement versus if the ultrasound beam is cutting the pylorus at an oblique angle, you might have like a thinner anterior wall and a thicker posterior wall. So I tend to wait most of the time you should do it in the long axis view and not a short axis view. And then I actually think this one is the biggest take home is the misidentification of pylorus. You can actually get a false positive and a false negative. So I'll show you what I mean by that. But things to do, Pedialyte will be your friend, or whatever electrolyte solution you have in the UK. Sweeties, you just keep the kid comfortable, warm gel. And then you might have to be a little bit more patient with this scan than some of the other scans. But these are some radiology images. So this was a 9-day-old baby with projectile vomiting and weight loss. So just looking at this, what do you think? The measurement here is 4 millimeters. This measurement here is 2-point-something centimeters. So pretty long. It's right under the liver. What do you think about this scan? Positive or negative?
Just wondering where the pitfall is, but yeah, I mean your length's certainly positive. You got your hypoechoic wall looks thickened. It looks to be stomach, so tracking from edge of pylorus into duodenum. But I'm guessing you're going to tell me it's a different part of the bowel or something.
I'm going to give you the pitfall right now. Actually, and this was a radiology performed scan. The pitfall is this landmark here. So the aorta is actually a really important landmark for abdominal imaging, SMA, SMV, and then for pylorus as well. So this is actually not the pylorus. This is actually the GE junction. So the distal esophagus feeding into the stomach here. So the pylorus is on the other side of this image somewhere. I know. And so what happened was this child had a repeat ultrasound the next morning because I think clinically the surgeons didn't really believe it, and the actual pylorus measured fine. And so here you can actually see the aorta down here with this looks like it's the celiac trunk coming off the aorta here, and the pylorus is not nowhere close to the aorta. So if you see a pylor, what you think is and I've been fooled by this before, if you see something that looks like a hypertrophied pylorus, make sure there isn't an aorta right next to it. And then this is the opposite case, I would say. This was a 3-month-old with vomiting and dehydration, a little older for most of our pyloric stenosis. And here we have stomach contents with some Pedialyte and little stuff going through transit through the pylorus there. This is also a radiologist scan, sagittal pylorus. They measured the muscle wall 2 millimeters, the channel length 1.1 centimeters, so less than 3.14. And this was called a normal pylorus on ultrasound. But what happened here is, here's my landmark. Look at my landmark here. Where can you see right there? Right there. This vessel, this is right next to that aorta. So this child actually had pyloric stenosis, ultrasound the next day. So, humbling cases. This definitely has the hot dog hamburger appearance. But yeah, that misidentification of the distal GE junction would be my biggest sort of take home for if you're doing a pylorus scan. I'm just gonna skip SBO stuff because it's all adult literature anyways. And we'll just do really quick. We'll do a couple of malrotation images, and then we'll call it. I mean, there's so much. There's so much richness in abdominal ultrasound. It's just hard to do it all in one setting. But malrotation. So this was in 2022 when there was a movement go more towards an ultrasound first strategy in the US by radiologists, as opposed to going straight to an upper GI, which was the reference standard. How when I was a resident and fellow, that was taught to the way to work up malrotation is an upper GI fluoroscopy study, which is not an insignificant radiation dose for usually what's like a pretty young newborn. And so this paper, which is great, described in a lot of detail the ultrasound findings, which is the SMV to SMA relationship, the deep 3 positioning, and that's for malrotation. And then for volvulus, which is what we should be able to diagnose fairly easily, is a whirlpool. And I'll show you what that looks like. I'm taking the laser pointer off. All right, so bilious vomiting in a newborn. And so this image here is what we're trying to capture. So we're trying to catch the SMA coming off the aorta with the SMV in the anatomical right of the SMA, and then the splenic vein sort of tapering this way. So we'll see the SMA usually in short axis in a bifurcation of the SMV and the splenic vein in the middle of the abdomen. When there's volvulus, so this is just malrotation. When there's volvulus, you're just going to see a swirling of the mesentery and the vessels and the bowel there. So it's almost like a small little mass that collects in the middle of the abdomen. I would do the image similar to pyloric stenosis, except if you're really worried about volvulus, I wouldn't be giving the kid Pedialyte because they might have to go to the OR fairly quickly. So no Pedialyte, but aside from that, I would do a similar scan positioning. And here's an example of a case that we diagnosed with point of care ultrasound. Actually, we thought this kid might have. We started looking at the pylorus and then just brought the linear transducer down a little bit lower, and we noted this swirling pattern and felt that, well, that's pretty abnormal. And here's the aorta. Here's the SMA. And then this is the radiology sort of follow-up image where you can see this, again, swirling pattern pretty close to the stomach, as you can see here in that image. And you put a little bit of color Doppler, and you see this whirlpool whooshing all the way around. Again, the SMA sort of sits in short axis in the middle of that kind of mesenteric twisting, and the SMV is sort of wrapping all the way around, and you have your aorta here pretty close by. You can actually get pretty good images with the curvilinear for this. Sometimes I almost prefer it, just because you can get the aorta, the SMA coming off of it. Here's the splenic vein. Here's this SMV. So either way, I think whatever probe, or you can go back and forth, but I think you could use the curvilinear for this. Just more examples here, same stuff. This is a child, a 2-week-old with yellow vomiting. So we consider yellow to be bilious in a newborn, and certainly I do. And just like a really fantastic image by a radiologist, stomach is dilated, all this proximal duodenum is dilated. The pylorus comes into view here a little bit right there. And you can see the contents are sort of going backwards into the stomach. The pylorus measured fine. And certainly when you scanned a little bit lower and look at this swirling mass here, more distal, right there. That's the main short axis. Aorta is here. That's just a still shot of the malrotation with megavolvulus. We put a little bit of color Doppler. So the same patient, really nice example of whirlpool swirling around there. So lovely images. Some other examples. This is a 9-year-old whirlpool, 6-month-old. These are POCUS images at other institutions. And then I think the duodenum is tricky. Finding the duodenum is a little bit more challenging than looking at the vessels. And so here you see kind of like anatomically, it should run between the SMA and the aorta. It's a really prominent D3 here, third portion of the duodenum, but it's in the right location, retroperitoneal, whereas here it's not as prominent. And so these are still images, so they're not video clips, but it's sort of wrapping anterior to the SMA. But I do think this is a lot tougher than just doing a rule-in yes or no question for a whirlpool type picture. And this is just a case series that we were lucky to be part of, with age range of patients that were diagnosed with malrotation with megavolvulus, with the confirmatory studies and the intraoperative diagnosis that most of them had volvulus, some had malrotation without volvulus intraoperatively. But anyway, I don't think we probably have time to do more. I talk so much. It's just so, but I'm happy to come back and do more topics at a later date if that's helpful. And I do have a summary slide somewhere here. Final thoughts. What happened? Why can I do this? This thing, that button. Okay. So yeah, great screening tests for several pediatric abdominal emergencies, especially intussusception. And then, yeah, the curvilinear will give you a big picture, and you'll need the linear probe for detail, or just for like smaller patients. There may not be a one-size-fits-all for your image acquisition, and there's a learning curve for sure. But what I usually tell folks that are really interested in doing this is you practice, you struggle, you practice, you struggle, you practice, and eventually you'll feel like you can succeed and become competent in these applications, and then be like Poirot, correlate your POCUS findings with the clinical presentation. And anyways, if there's any other additional questions, I'm happy to stay online for a little bit longer. I'm going to turn this off.
Any questions from the chat, guys? I know we've been fielding them as we've gone. You can either type them or speak up.